Hi, this is Dr. Eric Joseph. I'm really pleased today to be with a friend and colleague of mine, Dr. Robert Kotler, who practices rhinoplasty surgery. He's a rhinoplasty specialist in Beverly Hills. I've been practicing rhinoplasty surgery and otolaryngology in northern New Jersey for 25 years, and the two of us are friends. We know each other for well over 10 years. And I think what makes the two of us unique is that we both offer non-surgical nose job procedures that are permanent, utilizing medical grade silicone oil. And Dr. Kotler and I are here today to kind of talk about this. We had lunch the other day and had a lovely conversation, and we thought it would be instructive for our viewers to kind of get our opinions about microdroplet silicone oil for permanent non-surgical nose job procedures. What do you think, Dr. Kotler?
Yeah, it's great to be with you, Eric. This is a fascinating subject, and it's important that the world know about it because it has two missions for two different clinical presentations. Or people come in who are unhappy with one or more prior rhinoplasties. On the other hand, there are people who come in who have a low bridge and maybe a tip that's falling a little bit. They have some dissatisfactions, but they don't necessarily require surgery for that correction. If they've never had surgery, they can avoid the operating room by having the permanent filler.
No, I agree. Do you feel, are there patients that you feel that aren't good candidates for permanent non-surgical nose job treatments?
There are some patients who are candidates. First of all, one has to realize that the filler is an addition. It's an add-on to existing structure. If a person has a very large nose to begin with, then it may be that surgery is the only proper option. Because even though the filler can correct some minor imperfections, you're adding volume and people are not happy with a larger nose. The other more common reason is that if people have had prior surgeries and there's such a distortion of the tissues, including breathing problems, then the non-surgical option cannot solve all the imperfections. So a good examination is the start to arrive at a proper diagnosis, and then recommendations can be made. And by the way, some people require both surgery, particularly for breathing, and then the permanent non-surgical option for external imperfections.
Hey, I agree with that completely. Dr. Kotler and myself both specialize in rhinoplasty surgery and permanent non-surgical nose job treatments. And when I'm pre-oping somebody for a rhinoplasty surgery, I will discuss with them there's a 20% chance after surgery that you might develop a small indentation or irregularity, and we may want to address this afterwards so that if somebody were to say to me at a rhinoplasty surgery pre-op, I don't want to do that. For me, that could be a deal breaker. So I guess what you're saying, Dr. Kotler, is if a young lady has a large nose with a large dorsal hump and a bulbous droopy tip and a nose that's just too big for her face, would you think that she's a good candidate for injectable fillers in general, or probably better candidate for rhinoplasty?
More likely a better candidate for rhinoplasty. For example, you mentioned the bulbous tip, and in many people, there's a very active muscle that depresses the tip with smiling that makes the nose look longer and less satisfactory. Well, there's no way that a permanent filler can negate the force of that muscle. It's very handily managed in surgery where the muscle is released, and then that large bulbous tip will not depress with smile. So it's very important to make the proper evaluation and diagnosis, and from that flows the best answer.
I'm just curious because a lot of surgeons advocate it, and I haven't been able to get it to work. Have you had any success trying to paralyze the depressors of the tip with Botox to get a non-surgical tip lift? I have not been able to. Have you had success trying to do that?
I have actually seen patients come in who've had that Botox injection and report satisfaction with that. I personally don't perform Botox injections, so I don't feel that I have the skill. It may work for some people. I think it takes great skill, as I'm hearing from the patients, because obviously you only want to paralyze that one little muscle and not paralyze the entire upper lip. It's difficult to smile if there's too much Botox on board.
Yeah, you're not kidding. I just have a couple of questions for you that I've never asked you before. How many years have you been using microdroplet silicone oil in the nose for permanent non-surgical nose job treatments?
I've been using it over 40 years. I was very fortunate. Early in my career, I happened to have taken a period of time studying with a very, very talented cosmetic surgeon here in Beverly Hills. And I observed his surgical techniques and then spent time in the office. I saw him perform the injections and said to myself, wow, this is really good for patients. And I asked him if I could spend more time at his side, and he welcomed me, and that set me on to what has been a very important service for our patients.
You know, the last question I want to ask you regarding your 40-year experience, you and I, when we were chatting over lunch, we were both discussing the fact that the temporary gel fillers, which are in vogue today, like Juvederm, Restylane, and the like, that are more commonly used in the nose for a temporary non-surgical procedure, how they're associated in a small amount of people with necrosis, embolus, stroke, blindness. What is the worst complication that you have seen in 40 years of injecting silicone oil in the nose?
Happily, I haven't seen any of those. I've never seen an infection. I've never seen a so-called granuloma where you get a kind of a little nodule and that looks like a pimple that somehow won't go away. It's been quite amazing, actually, to perform a procedure with such a success rate and virtually no complication rate. There have been very few patients have a little temporary redness at the area of injection, which has gone away either by itself or with some medication. But as far as any catastrophic complication, happily, we haven't seen it. And I think there's a reason for that, or reasons, and I'd like to discuss that with you because I think you share the same view. The number one consideration always is the experience and skill and judgment of the injector. And since there is a large industry promoting the temporary fillers, often the work kind of drops down to non-physician practitioners, not to disqualify them automatically. However, often their training comes from a representative of the company, and without a residency or fellowship or apprenticeship, they often don't have the same skills and clinical knowledge that's essential to avoid complications. Physicians' assistants, registered nurses, nurse practitioners are among the more common practitioners of that art of the temporary filler. And so I think you have to look at training and qualifications and experience. And frankly, there is a huge advantage in the microdroplet technique because only tiny amounts are injected each time the needle pierces the skin. When you don't have a large volume of filler put in at one time or being kind of weaved through the tissue through a larger cannula rather than a tiny needle, that sets the stage for possible higher incidence of complications. So it's experience and it's technique.
And as the late great Dr. Jay Barnett said to me, because I asked, the nexus between Dr. Kotler and myself is through a now deceased mutual colleague, Jay Barnett, and I specifically asked Dr. Barnett when he was alive. I said, Dr. Barnett, have you ever seen necrosis after silicone oil? And he said to me, Eric, no, and you never will. I said, why is that? He said, because the size of a silicone molecule is smaller than a red blood cell. So if a little bit ends up getting injected into an artery or vein, it just flows through as opposed to occluding it. So all of our experiences have been the same insofar as nothing catastrophic, occasional redness at the injection site. I would say perhaps 1%, 2%. The overwhelming majority of people don't have problems with the procedure. So you and I both have a similar experience, and it sort of makes everybody who's listening to this think to themselves, well, why don't more people do this? And I know we spoke about this over lunch, and I think what you said earlier about the industry driving these temporary gel fillers is certainly an issue. And the other thing that we chatted about over lunch is that there's this misconception and myth out there that if you should have a problem with a temporary gel filler, it can be completely mitigated with the dissolving enzyme, and that is not true. There are people that develop chronic scar tissue and chronic fullness around temporary gel hyaluronic acid fillers. And so the temporary fillers are actually not completely temporary. So it's one of those things where I guess everything that's obsolete at one point in time was new and exciting. Microdroplet silicone oil in the nose has 60-year history of permanence, precision, and safety. Isn't that right, Dr. Kotler?
Well, that's right. And, it's interesting to go back to the original science that established the safety. The origins of medical grade liquid silicone, most people know it as silicon 1000, came from the world of ophthalmology, eye surgery. Detached retina was a problem before lasers were available. We're harkening back to the 1960s, for example. Laser technology wasn't available, and the detached retinas were the inner lining of the eyeball, which is like the film in a camera, if one remembers cameras with film. It pulls away from the back of the eye, and when it pulls away, then there's a change in vision, and it's a serious situation. And so the eye doctor said, well, if we could only put some more clear liquid inside the eyeball to push it back and hope that it sticks to the back wall, like wallpaper that's come away, we got to make it stick to the wall. We need some glue. Well, glue wasn't available, so Dow Corning, which was a very well-established manufacturer of all silicone products, got the job, and they did it. And they produced a clear, colorless, injectable liquid. It was injected into the eye, which is certainly the test of sensitivity and the measurement or ruler of complications. And it worked. It worked beautifully. It became a standard, and the FDA approved it. And so then, as happens in medicine, other uses came to mind. And one use was, again, well, how do we correct the dips, the divots, the trenches, some imperfections after an imperfect rhinoplasty? And the answer was, why can't we just plump the skin up a little bit and fool the eye and make it look like the excess cartilage suddenly returned after it was removed? And so it's a filler, and it makes up for the absence of cartilage, and it's safe. It's incorporated into the skin. And I actually have a letter that was sent to a colleague from the FDA in the 1980s at the time of a medical journal article that came out that we're both familiar with, that, again, cited this long track record. And the FDA said, we consider it safe to have micro droplets injected into the skin, because the major test of safety and lack of complications was the testing that the ophthalmologist did inside the eyeball. That was a high standard.
No, I agree. So one other question. After 40 years of using microdroplet silicone oil for permanent non-surgical nose jobs, would you ever advocate the use of a hyaluronic acid product in somebody who's had previous nasal surgery and has imperfections?
Well, I am asked that question, like, why don't I use that? And yes, it's been around, and by and large, it's been successful. My answer is, if a patient asks me, well, what's it going to be like after the injection? My answer is, well, it'll be great. And then after a period of time, the dissolvable filler will be absent, and you have to repeat the cycle. So people would like to have permanency. People would like to have their problem solved and not be sentenced to a lifetime of refills of the gas tank, so to speak. And patient has an option, though. If people want to have a temporary filler, fine. I don't perform that technique because I believe that it's in the patient's interest to have a permanent filler and would like to provide that service. But if they'd like to have it done by the temporary route, I'm glad to refer to colleagues who have expertise in that arena. It's really up to the patient. However, most patients are not aware of the permanent option. They're not aware of the Silicon 1000 because there is no multi-billion-dollar marketing and advertising campaign that it envelops their thinking.
So that's interesting. So do you think that most people who get a non-surgical rhinoplasty with hyaluronic acid, do you think that most people are not informed about the low likelihood chance of necrosis, biofilm, blindness, stroke, embolism? Do you think they're not informed, or do they just not know that there's a permanent option for them?
It's a good question. They may not be as well informed. This depends on I think the quality of the consultation, which should always discuss not only the benefits, but the risks and possible complications. But more importantly, they just don't know about the permanent filler. It's not advertised on television.
Right.
It lives in its own world of just a few practitioners such as we who recognize the benefit to the patient. And I think all patients would like to have frankness and the facts from a professional during a consultation, and I'm glad to discuss the pros and cons of both the temporary and permanent filler. I think one of the best ways to understand the value and importance of the permanent non-surgical rhinoplasty is to see before and afters. Those are the currencies of success. And we all have cases that we remember fondly. And I'd like to ask you, Dr. Joseph, to show us an example of what you consider a standout case.
Sure. This young gentleman that you see on the screen, he had previous rhinoplasty surgery, and he has many of the stigmata of previous rhinoplasty surgery in a patient with thin skin. He has nasal tip basse or visible cartilage in the tip. He has an over-resected bridge, some will call that a saddle nose deformity, and he has excessive nostril show. But the size of his nose is an appropriate size for his face. So he doesn't have a nose that's too big. And frankly, he didn't want to undergo a tertiary operation after having 2 failed surgeries. So over the course of 4 treatments, you can see that we've achieved, instead of a ski slope on the bridge of his nose, we've achieved bridge raising with a less operated bridge appearance, nostril lowering with filling of the supraalar creases, and camouflaging the visible cartilage through the tip of his nose. And this eliminates many of the stigmata of previous surgery. And he just particularly comes to mind because I thought he had just about every one of them. And since his nose was the right size, we were able to camouflage these irregularities with no downtime, minimal inconvenience for him, and it's completely permanent. And that was well over 10 years ago. What about you? What about you, Dr. Kotler? What's one of your favorite cases that stands out in your mind as something exceptional?
Yes, there are some cases that you always remember, and it's good to have a big victory. And the big victory for a middle-aged lady who came up to see us, who, by the way, acted not like middle-aged, but as a very youthful person down in Orange County. She had 5 rhinoplasties and was getting desperate for improvement. And unfortunately, there are cases like this where people have 2, 3, 4 surgical attempts that fail. And patients are literally, they're desperate. They're unhappy and they're desperate. And that's why I'm pleased to be able to help them without surgery and to offer a more predictable and practical solution rather than the uncertainty of yet another surgical exercise. As you see, for this lady, the nose was just overdone. It was overshortened, meaning the bottom of the nose, between the nose, the tip of the nose and the lip has been shaved off so much that it looks terribly unnatural. And the bridge is unnatural. And the entire nose looks wrong because too much has been done. throughout the series of surgery, the net reduction in the volume of the nose became very, very obvious and unsatisfactory. The answer was to restore volume. And we plumped out the bottom of the nose. We got the bridge to look more natural, corrected the imperfections of the tip, all of which worked because it was done sequentially. A little bit, 6 weeks later, a little bit more, because we have to respect the body's tolerance for inserting a foreign or man-made material. The body likes to be fooled in a little bit at a time, and also so we don't overfill. So those are the two guiding principles in injection. One, and most importantly, don't overfill. And secondly, don't stress the body. Always less rather than more. Needless to say, she was very happy, and we're very gratified, because finally the unhappy book, the unhappy story of her nose surgery has been closed. And again, the fact that it's permanent is a source of great relief to patients to know, it's over, it's done, okay, the surgeries didn't go well, but I was bailed out. And that's very gratifying. And I see the smile on your face because I know you agree with that.
Well, yeah, I also want to share with our audience that's watching it, that's looking at Dr. Kotler's before and after photo, that those few millimeters of nasal lengthening that he was able to achieve is unbelievable. How a few millimeters makes the difference between a done-looking, over-rotated nose and a natural nose that doesn't call attention to itself. And I would venture to say that most people who do temporary non-surgical nose job treatments with hyaluronic acid do not ever inject the columella or infratrip lobule to get a little bit of lengthening. So that's a very lovely, artful example of the precision and the millimeter effect of turning a done-looking nose into a nice nose. So that's a lovely example.
Thank you. Yeah, it is. Dr. Joseph, often the key word, if you will, is precision. And that, of course, is extremely important. And in my view, precision comes when you have the ability to make very minor changes, so you're not overcommitted. And so between a product that is easy to inject through a very fine needle, we have an entree to correct the problem. And I think that's one of the keys in understanding the difference between the dissolvable fillers and the permanent fillers, because one needs a larger bore needle or cannula to insert the temporary fillers rather than the very, very tiny, almost invisible and short needle needed to facilitate the silicone injection. I'd like your thoughts about that, because people appreciate precision work, and every detail, and you alluded to millimeter by millimeter, counts when it comes to correcting an imperfect nose.
Oh, I agree with you, and I think that those are very interesting points insofar as the practical application and being able to be precise. With the case that you're looking at on the screen, this is somebody who also underwent several rhinoplasty surgeries, and as you can see on the photo on the left, there's a crooked nasal appearance and there's asymmetrical nostril retraction where the patient's left nostril is higher than the right. I know you would agree with this, Dr. Kotler. I don't think that there's any better way to lower somebody's retracted nostril margin in the year 2025 than to utilize a little bit of delicate silicone oil right at the area of retraction, which helps them to come down. So in this particular example, the before photo, what's striking about it is when the two nostril holes are different sizes, that catches the eye. It looks distracting, and the left side is very high up. Plus, there's a wide nose, but a wide crooked nose is more distracting and not as aesthetically pleasing as the same with straight nose. So in this particular example, the goals were to provide a straighter nasal appearance and to decrease the nostril show and to improve upon nostril symmetry. And the aesthetic goals were able to be met with this patient because her examination was favorable. And she, as you can see in the after photo, she now has a less operated looking nose without undergoing a fourth nasal surgery. And it enables the patient to many times to be able to put what's been bothering them about their nose on the back burner, because it is amazing how some people after several rhinoplasties can be bothered by the tiniest little thing, and making that tiniest little imperfection or asymmetry disappear can be some of the most rewarding things that we do, right? It's really
Absolutely
amazing.
correct. And because the nose is in the middle of the face, asymmetries are more visible. In other words, if you compare two ears, well, you've got to have your eyes go back and forth to look at one ear versus the other. But when the nose has asymmetries, it's right up in front. And eye contact includes nose contact when we're speaking to people. And patients are very aware of that. And as you pointed out very handily, they'll pick up the imperfections and asymmetries. The world might not, but that's what's important, is that they are unhappy and their needs have to be addressed. And to be able to make these very precise, minute corrections and deliver satisfaction with an office treatment that takes fewer than 5 or 10 minutes, I mean, that's medicine at its best. In other words, physicians serving patients, which is what this is all about. Our goal is to help patients, just like it's the goal of heart surgeons to heal an imperfect heart or correct the birth defect. All those things come down to the common denominator of physicians are here to help people. And if we can help the patient with a safe, predictable, reliable, and economical solution, that's pretty good.
No, I was thinking, Dr. Kotler, that both of us gave examples of permanent non-surgical nose jobs on noses that have previously been operated on. Do you have an example of somebody who's not had nasal surgery that perhaps has a dorsal hump that they didn't like, that you've permanently camouflaged a dorsal hump without surgery?
That's right. I'm glad to demonstrate exactly that type of situation. Remember, every patient's different. And some people don't even realize that they can have satisfaction without surgery and are amazed when they are offered the opportunity. For example, a young lady here, she had a bump and it's most obvious on the profile, never had surgery, and frankly wasn't keen on having surgery. And that's fine. Everybody's entitled to their own view of what they'd like to have. And I proposed to her when she came in, basically concealing the bump on the nose. And you conceal the bump by putting filler above and below. It's as if you wanted to give the illusion of a mountain disappearing. You fill the valley next to the mountain and you no longer see the mountaintop. So creating a level profile without surgery, even though you're adding on, can be very practical. And patients understand the concept. And when explained in the common kind of similarities that one sees in life, I think they can appreciate the opportunity.
But by the way, I love this example because it's a small dorsal hump. So I think just to utilize Dr. Kotler's verbiage, when patients come in and the peak of the mountain is too high, sometimes it's only surgery, because adding permanent volume to a large nose is only going to make it larger. So I love the example because it's not a terribly large dorsal hump, and by adding the volume to make it less distracting, it makes her nose less distracting, and she looks prettier. So lovely example.
Yeah, and I want to say too that the analysis at consultation is very important. You have to look at all elements of the nose. First of all, is the volume of the nose too much for the face? Often people have a small face, a small skull. And if they've been unblessed, if you will, with a large nose when their grandfather or grandmother, well, there's only so much you can do to conceal the imperfections because the big problem is the big nose. Well, that usually calls for surgery, but you have to analyze and look at everything. And there is no one right way for everybody. And patients' desires need to be listened to. I think we have to be, and I know you are, a good listener. I think the first obligation of any physician is to ask the question, what don't you like? And what would you like to have? Because we need to know, because our eyes may stumble upon something that's not relevant to the patient at all. But most importantly, what would the patient like to have? What is their vision? And then we have to come up with solutions. And when we make the right suggestions and offer the right solution, and the patient is amenable to it and appreciates the thought that's gone into it, we're going to have a happy patient and a victory. And that's what it's all about.
What would you do if somebody came into your office like this example that you showed, and she's a little hesitant about perhaps utilizing a temporary filler, and she wanted to get an idea of how things looked, and she didn't want to deal with a temporary gel filler that could cause necrosis or other problems? How would you deal with showing a patient how they would look after a permanent non-surgical nose job without it being permanent?
Well, that's a great question. It opens the door to a discussion of full understanding of the potential and what can one see to gain confidence that that would be a wise undertaking. There are really two ways of presenting the vision. One is through computer imaging. I've always been a big fan of computer imaging. We've done it for many, many years because to be able to see a rendition that is satisfactory to the patient as they look at the computer screen is very valuable. Otherwise, you're just words and abstract communication. This is a visual subject. It's about how things look. And if you can demonstrate on the screen the likely outcome, and if the patient is happy with what they see, that's a good green light. Now, there's another option that we've worked with for quite a few years. It's called the saline demo. The saline demo is the injection of sterile salt water, which mimics the result of the permanent filler. In other words, it's a test drive. It's a see the results before you decide on whether you'd like to have it or not. Now, this is akin to trying on shoes or try on clothing. Do you like the look? Is it satisfactory? And then it disappears in 2 hours. And that is a practical way that a look in the mirror tells the tale. If you like what you see with this 2-hour temporary, then you'll be happy with the permanent filler.
Because of your advocation of saline demos, I do them now as well. And that was a lovely pearl that I learned from you. And I don't do them all the time. But if I have a patient that I'm not completely certain I'm going to make them happy, that's the time that I would do a saline demo. Because sometimes people can communicate with you their problem, you see the problem, you know you're going to be able to fix it, they want to move forward, we do it. Sometimes, and I know you'll agree with me, we're having conversations where we kind of see what the issue is, we can show them on computer imaging, they're not that thrilled with it, so then I do the same thing. Let's try a little salt water, live with it for a few hours, it'll completely dissipate, and if you think it's the best thing since sliced bread, come back in a few days and we'll do it permanently. So
yeah, I think it's fun to do because in a way you're often amazing the patient. They say, I can't believe this. And I said, well, the mirror tells the truth. And by the way, as you do, of course, because we all do, we take a set of photos before and then you take a set of photos immediately after, and they're available for the patient to ponder, to share with family and friends. And by the way, I want to mention apropos of that, I like to have family and friends come to the consultation because I think it's great to have some support and feedback and a second objective view. You know, when we're looking at ourselves, it's always subjective. When others are looking at us, you'll get a more objective and perhaps realistic assessment. And when the the family or friend member says, "Oh my God, that looks good," then I think there's some backup to your presentation that makes sense. But I think that to be able to visualize results in cosmetic surgery is very important. As you know, when computer imaging arrived on the scene, and this goes way back to the late 1980s, it was a byproduct of the beauty salons' desire to show their clients what a new hairstyle or new color would look like. I first saw that at a convention and said, "Wow, that's pretty neat. Why don't you have this for cosmetic surgery? We can show somebody what their new nose will look like." And the representative of the company says, "You know, we already figured that out. We're working on it. See us in about a year." And then they came up with the cosmetic surgery computer imaging. And it was a tremendous advance in communication. It's a communication tool and an educational tool, as is the saline demo. So I really enjoyed proving to sometimes and often skeptical patient, yeah, there's a non-surgical answer to your dissatisfaction. And if someone is happy with the saline demo or even the computer imaging, I think that they'll be happy with the final result of our intervention. And again, bottom line, we're here to make people happy. We like smiles.
I agree. Well said.
Yeah.
So Dr. Kotler and I would like to answer some questions that were submitted from our audience. The first question that was asked is, does the filler migrate over time like non-permanent fillers? What's your 2 cents on that, Dr. Kotler?
The patients ask about the issue of migration, and following the rules of nature, I'm pleased to tell them that that doesn't happen. It doesn't happen because nature will build an invisible wall around the micro droplets of silicone and stabilize it. You know, I was in the military and I saw veterans from World War II. They had pieces of metal in their body, and the metal had been there for 30 years. It wasn't causing any trouble. It was under the skin. It wasn't near an important organ. And often they had failed to remember that, yes, I had a little injury at the Battle of Anzio or wherever. And we said, well, if it's bothering you, we take it out. And if you don't mind it, it can stay there. And it did stay there for these people because nature accepts it and doesn't let it move. Well, that's what happens just under the skin where the permanent filler is placed. So it is permanent, and it's permanent by virtue of the typical behavior of the body. It tolerates the product. That's the genius of the inventors or developers, and yet it keeps it in place. And the temporaries will either, by their own temporary longevity, disappear, or often could spread a tiny bit. And therefore, I see them as less predictable and definitely not permanent.
Yeah, I agree with you and everything that you said. We have not seen migration of silicone, for instance, from one part of the nose to another over 25 years. It doesn't happen. I agree with you about the body walling off each of those little micro droplets. And just to give the audience an idea, a typical treatment for a nose is anywhere between 1/10 of a cc to perhaps 6 or 7/10 of a cc maximum, and 1 cc is 1/5 of a teaspoon. So we really are talking about very small droplets of product that are being deposited into the soft tissue underneath the skin of the nose. It doesn't migrate for the reasons that Dr. Kotler mentioned. And I think, you know, one of the problems with migration in silicone are when people end up having illegal buttock enhancement or augmentation injections by a non-physician in a hotel room. And if somebody has a pint or a quart of industrial grade silicone injected into a gluteus maximus, sometimes some of that can get into the bloodstream and cause pulmonary edema and death. And unfortunately, there's one or two people that die every year from a pumping party in a hotel room, and that's completely different than what Dr. Kotler and I are advocating right now with the micro droplet technique, the volumes that are used and the small amounts that are being deposited. It just simply doesn't migrate.
And you know, I'm sorry.
No, go ahead, Bob.
There's another feature that I think patients understand, and that is the nose is a non-moving part. And when you place within a non-moving part a foreign material, there's no stimulation to make it move away. And that's another advantage for the nose in particular, and why it's so important there, because it will stay and it'll behave itself very nicely.
So the next question that came in from the audience is, can one session bring results? What say you?
I'm an advocate of slowly but surely. Two reasons. Number one, again, it's better to fool the body with a smaller volume per injection session. And number two, by doing it incrementally over some period of time with an interval between injections, you won't overfill. Because if it's just one injection, what if, for whatever reason, you went beyond the expected volume? Well, that's a bit of a negative. So in my opinion, it's better to creep up towards the end result. A slow, steady march to the goal line, not necessarily a Hail Mary pass that may or may not make it. So football analogies work.
I agree with you. I think insofar as does one session bring results when I'm consulting with a patient, I think a lot depends on where the irregularity is on the nose. I think in the lower 1/3 of the nose, where the skin is relatively densely attached to the cartilage, it's easier to fill an indentation or an irregularity as compared to the bridge of the nose, where the skin is a bit more loosely attached. So I will tell people, I'll counsel them that when you look in the mirror after your procedure, what you're looking at is a final result with some swelling, and that swelling is going to work its way out over perhaps a week. And between 1 to 2 weeks after your procedure, you're going to be looking at your final result, and you're going to understand why several treatments are typically necessary for a desired result. And I can't overemphasize what you just said, Dr. Kotler. And there is an impetus for somebody who's not trained in the serial puncture microdroplet technique to put in too much, because Silicon 1000 is a much more subtle filler than a hyaluronic acid filler, which is hydrophilic. It loves water, and it's a large molecule. So somebody gets a Juvederm injection and their nose might look a bit more full the following day because of the properties of the actual molecule. So it's completely different than silicone, where we expect the swelling to go down and we expect to do several procedures, where with a temporary filler, because of its properties of holding on to water, it tends to be more one and done. So different product, different chemical properties to the fillers, and different techniques.
Another aspect that I kind of learned through experience and time and listening to patients is that the interval between the injection sessions turns out to be very important for one other reason. It gives the patient a chance to live with their nose for 6 weeks, and maybe their desires or their expectations may change a little bit. They may say, originally we weren't going to put too much into the tip to raise it up, but now that you put some in, I really like it, and maybe I'd like to have a little more. Can we talk about that? See? In other words, there are no decisions that have to be made on the spot, because it is a matter of the patient's desire, the patient's taste. And that often can kind of develop over a little period of time, and that's good. It's better to have time to think about things than to make a often rash decision on the spot. Again, the bottom line is always, what would the patient like to have? What's good for the patient?
Our next question is, how long does it last and what is the recovery time?
Well, the first question is easy to answer. It lasts as long as the patient lasts, and there's no recovery time. You have the filler placed, and you leave the office. And our only admonition is don't think you need to rub your nose to make this process effective. Just hands off. Nature will take it from here. Otherwise, your life goes on. Normal washing the face, normal exercise, a normal life. That's quite remarkable. To walk into an office looking one way and walk out another way, having had a permanent change in obviously less than a half hour total time in the office, perhaps. That's pretty remarkable when you think about it.
I agree with you on both of those points. It's painless, it's completely permanent, and there tends to be no downtime. As a matter of fact, people will look better immediately after the procedure because they haven't lost any swelling yet than they will a week later. And they go, "Doc, where did it all go? You didn't put enough." Well, we need to go slowly because if you put in too much on round one, you can cause an inflammatory response, and that's part of the learning curve of doing this. The last question we have is: have you seen any cases of blindness or necrosis?
I've not. Happily, very happy that I have no such experience.
No such experience after 40 years?
That's right. And that's why I'm very enthusiastic about offering to patients. I mean, every physician's desire is to help patients and have a very favorable risk-reward ratio, meaning very little or no risk versus a big reward. Surgery does not offer that same ratio, frankly. We have to be realistic and honest and forthright with our patients that one cannot ever warranty or guarantee the result of surgery. The odds are very, very good in experienced and well-trained hands that there'll be a favorable outcome, but it can't be assured. This is a much better bet for most patients.
I agree with you completely. We haven't seen any cases of blindness, necrosis, or infection after 25 years. Dr. Kotler, I really want to just take a moment and thank you for taking the time to do this meeting with me. It was lovely seeing you the other day. It's nice to chat. It's always nice to chat with you and to see you and to share thoughts about what you and I do on a daily basis in the office is really a lot of fun. For anybody who's out there on the West Coast that is interested in this, I would send my family to Dr. Kotler. If anybody's on the East Coast and think that they might benefit, I'd be happy to take care also. And if anybody out there would like to visit us for a consultation, just go to our websites and get in touch.
Amen. It's good.
Amen.
Amen.
Nice seeing you.
Thank you very much.